Oh, that's a great question because, again, there's a lot of data, ours and others, that say Black women are more likely to have more invasive surgery and to have open surgeries instead of minimally invasive surgeries. And I think really is that an issue of access? Is it an issue of preferentially uh, giving minimally invasive options to one group of people and not to another? Or is it really that the disease is more advanced in Black women? And we know that there's some reasons to do that. So I think at this time we can't disentangle it. But we can start to ask the questions, am I offering the full range of options to every individual? And not preferentially deciding this is better for this person and that is better for another person. And I think it's also important to be asking research questions such as this, because I think that's really important. Our general feeling is that we need to diagnose fibroids earlier for everyone. And that's one of the reasons why in the COEQUaL study, we're studying not just OBGYNs, we're trying to look at primary care docs, nurse practitioners, women's health PAs, to see what are the barriers to treatment at these earlier places, because we know that it often takes time to get referred to an OBGYN. And then especially if there's a bad interaction and somebody walks out the door, they may not come for a long time. So I think there's multiple ways to start to understand this, but I don't think it's clear at this point in time. This is a biologic variable. This is a cultural variable. This is an access to care variable. Well, I think it applies to every patient. And I think the first thing is to not come in and say, well, with this fibroid, you should have X, that's the way many of us who were trained as surgeons were taught to do. I'm the boss, I know what's best for you. I think to start by asking, what are your goals? What informs your decisions? And just a couple of examples from my practice. I remember one lady where we were talking about hysterectomy. And I said, well, what concerns you about hysterectomy? And she said, well, my mother had a hysterectomy and died on the table. And I'm going, that's a very good example of why understanding what's going on here is very important. A second example that I've learned from my research is that many of us who are OBGYNs say, well, you could take birth control pills. And for me and my colleagues, we think this is a hormonal treatment that suppresses ovulation, gives you continuous treatment, and helps really with the heavy and abnormal bleeding that women experience with fibroids. But what many individuals hear is, why are you telling me to take birth control pills? I've already told you I'm not sexually active. Did you not listen to me? Do you not believe me? And so I think that even with a two-way conversation, our assumptions are different on different sides. And I still don't know the answer to that one, because to say, well, birth control pills are actually more than birth control, they're hormonal therapy because of this and this and this and this. When you have a 20-minute or a 30-minute visit, it's hard. But I think to understand that those burdens are there, and to educate providers and educate patients and to try to get more of a dialogue is what's really critically important. So I don't think we have data on where disparities most consistently arise, but we do know from a lot of our research and that of others that for Black women, they develop fibroids at an earlier age. They have more severe disease. And particularly when you're dealing with an individual who gets early disease and then is trying to finish law school or trying to build a business, postponing pregnancy comes into play. And so we believe that diagnosing and intervening early may be an important tool to minimize disparities. And so that's one of the reasons our projects are looking at barriers, not only for patients, but also for primary care providers. And I think the model that I would love to see is what's evolved in cardiology, that you don't have to see a cardiologist to get placed on a statin or to be started on blood pressure medication. A primary care doctor does primary cardiovascular screening, institutes initial therapy, and then only if you fail that or you have very severe disease do you get kicked up to the cardiologist. And again, if we had NPs who do adolescent medicine that said, oh, you have a fibroid and you're already telling me your periods are lasting 7 days and you've got some mild anemia, maybe I should be empowered to do something other than trying to send you to a gynecologist. And so that's one of the underlying hypotheses of the COEQUaL project, is if we can understand the barriers to get access to care earlier, with earlier diagnosis and earlier referral, then maybe there will be less severe disease that prompts one woman to get a minimally invasive procedure and another one that gets a more invasive option.